right, so you got to see a lot of life-saving technology and a lot of fancy valves. I'm here to talk about high blood pressure. So, the only good thing is there's been a lot of changes recently. If this talk was 5 years ago, it would be exceedingly boring, so we're going to move right into it. So a little bit on the guidelines. We saw a big guideline change right before I agreed to do this talk, actually, was the 2025 guidelines that came out back a little while ago. We've been in 2017 for a long time, so I want to focus a little bit on what's changed in the last two things. And what we do as not just everyone, but treatment of high blood pressure, has it changed from, a couple months ago to now? And then what is resistant hypertension and what do we have available, which again wasn't available until a couple months ago, and that's specifically with renal denervation. And not only is how the procedure and all that stuff is, but who do you want to refer to a hypertension specialist? So first of all, does anyone know off the top of your head what % of Americans have hypertension? Sorry to make you wake up, but it's 47%. So we're talking about trickles of tiny numbers of people with heart failure and valves, sorry. But this is the vast majority of Americans, is half the people have hypertension. So if you look at impacts, the population is exceedingly high, hundreds of millions, well, if you want to go really billions of people in the planet. So again, 40% of patients, and it's a leading modifiable risk. So as a population, there's a big bang for buck in fixing hypertension, which again, we live in this wonderful state where it's a little bit more prevalent. So a lot more evidence, particularly mentioned in the 2025 guidelines, are a large link and emerging between cognitive decline, specifically related to vascular dementia. And like I was saying, the more time that we have with normal blood pressure, the better, and it's a large impact. So what's the stuff that didn't change? So the same categories as last time, so we don't need to memorize any new tables or update any textbooks. Normal or elevated is less than 130. Stage 1, 130 to 139, or 80 to 89. And then stage 2 is exactly the same, is 140, 90. And then severe, again, exactly the same, 180. And then treatment goal, which again is the same as the 2018, is less than 130. So that's the stuff you don't need to rememorize or retrain. And I'm going to give you some new stuff, but I don't want you to take everything to heart, because there's been some controversy and some great things. So again, who do you start treating? If this were a textbook, it would be the same thing. Someone with stage 1, which is again less than 140, plus a high cardiovascular risk, you start medications. And this is the biggest change actually from the previous guidelines. Notice I didn't say lifestyle modifications, bring them back in 3 months and start all over. This is the biggest change between the 2017-25 and the 2025 guidelines, is early intervention and treatment in people that are high risk for cardiovascular disease. So again, this is stage 1 people. Of course, lifestyle is a huge point, and we'll talk a little bit about that, but it's high risk. So that's specifically people with diabetes, cardiovascular disease, kidney disease, or this PREVENT score. Now, to go off on a little bit tangent on the PREVENT score, some of you are familiar with the old school Framingham score, which is the hospital I was born in, by the way. And then the more recent ASCVD risk, these are all pooled cohort equation formulas that either use smaller populations and now have been updated to larger populations, but requires lots of input. There's almost 12 variables that goes into the PREVENT score, which I think is very clunky to do in clinic, but the gestalt is the most important thing. Someone that has high cholesterol, family history, and all these other things obviously is going to be a high risk category. So they emphasize heavily the PREVENT score, which I think is great if your EMR can do this automatically, but taking out your phone and typing all this information during clinic visit, I don't think is the right thing to do. So again, early treatment in people that have high blood pressure with additional lifestyle or counseling, but not to delay treatment. And then stage 2, they recommend upfront 2 medicines, and ideally single pill combo. And I don't know if any of you have too much experience, but insurance cover is either completely fine or absolute no on single pill combinations. But that is technically the recommendation now for anyone that has stage 2, which is not what most people do, by the way. But again, according to the new 2025 guidelines, is definitely what we should do. And then there's more emphasis on screening for not vanilla hypertension, so urine creatinine to look out for early kidney disease on anyone with hypertension. That's irrespective of the stage. That's in anyone with even stage 1 hypertension. And then this came out from a paper when I was a resident back in the day, but primary hyperaldo was actually one of the largest missed diagnoses of resistant hypertension. And when I say resistant, I'll talk a little bit more later, but it's people that are on essentially 3 medicines, one that's a diuretic, or anyone with sleep apnea. So this should be a big, and that's one of the other reasons why I love aldactone as a medicine for people with resistant hypertension, even in general, but you should always think of primary hyperaldo as anyone that's on essentially more than 2 medicines. Battery's dying here. Now, lifestyle is very, very, very strict on the new guidelines. So I want to say, like Katrina was mentioning, the less or no alcohol is a big deal, but the sodium restriction that they recommend is less than half of what the average population in America eats. Even healthier people, I would struggle to say, have less than 2 grams of sodium. That's even less than the normal dietary guidelines itself. There's even a paper back when I was a medical student that had a sodium restriction of 1.2 that was eventually pulled from circulation because it was thought that that was impossible. So that's the recommendation, and that's a goal. That doesn't mean that everyone's going to get there, but that's currently the biggest bang for your buck. And then weight loss exercise that, other people have talked a little bit about. And then home blood pressure monitoring is to rule out white coat hypertension. And how blood pressure is measured is also a big change in the guidelines. So they also had it almost like Katrina was saying, wherever she is. But almost half the time, readings that were then repeated were wrong. So if you're looking at just walking into an office and taking the blood pressure off the chart and going with it, that means that half the time that's wrong, which is kind of terrifying when you really think about it. So in the interest of time, I'm gonna go fast, but relax, take blood pressure as important. So again, to reiterate, when to start meds, stage 2 is 2, or stage 1 with risk factors. And then lifestyle is a lifestyle first. That doesn't mean that you don't do any lifestyle, just to go back on that. So make sure that we talk about medical therapy up front in people that are of high risk for cardiovascular disease. And then the official answer, because I'll be good, is use the prevent calculator. But realistically, remember, the prevent calculator is just people with high cardiovascular risk, diabetics, kidney disease, people with uncontrolled high blood pressure, family history, all that stuff. Now, again, targets, like I said earlier, 130, and then there are some newer caveats. There's been a de-emphasis and over-treatment of hypertensive in elderly people, which is, again, obvious, and most of us actually do that, but it's a little more formalized. And then home blood pressure data is still very popular, which, again, it's hard to get insurance to do any of this, but still is better in the clinical trial setting. All right, I'm going to be really fast because we got the fun, sexy stuff to talk about in a little bit. So ACE inhibitors, thiazide diuretics, calcium channel blockers, we all know 2 med combos are better. This is just the first line stuff. And then ARBs are kidney disease and diabetes. And then GLP-1s, where another shout out to Katrina here. All right, I want to talk a little bit about the impact of all this stuff. I don't know if you can see very well, but I want to look at the actual percent or actual systolic points that some of these recommendations have to do. Weight loss is actually probably the best. So you can see that 10 kilogram weight loss is between 5 and 20 systolic point reduction. But if you look at diet, we're around 5 to 10. Stress reduction, so if you take up yoga, it's about 5. Physical activity, again, 5 to 10. And this is important because I'm going to compare it about something in the future. And then diet, salt, we're again 5 to 10. Alcohol's even less than that. And then tobacco is not as important, but again, for high blood pressure, it's not important. But again, we're around 5 systolic points. And these are long-term data over long periods of time. So again, I'm going to go through this really fast, but be careful about older people. Overtreatment's not a good thing. And what happens when we get on the high end? So severe, we're talking 180, and this is actually in the guidelines as well, is 180 without end organ damage is outpatient. That's not in the ER, that's not admit to the hospital. I can tell you we probably see, 2 of these every single day in the hospital, but it happens all the time. But again, requires end organ damage. All right, we're gonna move on to the fun stuff quickly because I know that's where the most bang for our buck is here. So resistant hypertension, and this is important for the last half of this talk here, is 3 medicines, 1 that has to be a diuretic, or more than 4 medicines, which is almost always the case. So first step would always be verify if this is real or not. If you look at some of the early trials for advanced hypertension, they were marred by people not taking their medicine. So some of the earlier trials even mandated people take their medicine in a witness setting and check their blood pressure because it was so hard to screen patients. And that led to the failures of some of the earlier interventional hypertension trials as well. And then secondary causes. Now, increasing diuretic potency is a good, especially in people that are more prone to, that they're hypertensive because they're retaining water, is using more powerful diuretics than just the good old-fashioned hydrochlorothiazide. And that's more escalating to loops in people that have kidney dysfunction or adding aldactone, which again is my favorite medicine for resistant hypertension, if I haven't said that already. And then primary hyperaldo is missed in I think 32% of people that have resistant hypertension. So this is a big problem that gets missed. And screening for all that is simply with renin and aldosterone ratio. And then untreated sleep apnea is another one. So treating sleep apnea to improve hypertension and a host of other things is an important thing. So obesity and sleep apnea are big misses as well. And then if you have, again, 3 medicines, you've ruled out primary hyperaldo, and you've treated sleep apnea if they had it, that's the point to refer. So I want to say that again. 3 medicines, no other stuff, and still uncontrolled. That's when we want to see them. So second part of the fun talk is what's changed? What do we have available? Well, there's a big connection between your brain, your blood vessels, and the kidneys, and that's done through the nervous system, which unsurprisingly is why renal denervation gets its name. So the effects on neural signaling from the kidneys to the brain and vascular system leads to renin release, which is a bad thing. Activation of the renin-aldosterone system, increased fluid as a result of that, and venoconstriction, which all unsurprisingly leads to high blood pressure. So the theory, and this has been going on for 20 years, we've been trying to get this system right, and finally it's there. So the whole purpose is that nerve signaling from the kidneys is what's raising blood pressure, and that denervating or ablating the nervous system is actually what is going to, by reflex, cause lowering of high blood pressure. So other 2025 guidelines, they actually included renal denervation in the 2025 guidelines, and it's a 2B recommendation for, again, true resistant, and that means ruling out the stuff that I mentioned earlier. So catheter ablation of those nerves is how we do it. It's simpler than it sounds. It sounds like a very fancy thing, but it's about the same as a heart cath. A small femoral artery catheter that gets snaked into the arteries in your kidneys. We make sure there's no blockages, and then we get to play for about 20 minutes burning a bunch of small areas in the arteries. But it's, as far as interventional procedures, it is fairly straightforward. So there's 2 devices that are approved for this, one that uses ultrasound and one that uses RF energy. There's a whole bunch of copycats coming out, I'll tell you too. So according to the most conservative estimates, we're talking about a 5 to 10 systolic reduction. Now, if you remember from my lifestyle slides earlier, that's on the realm of salt reduction, weight loss, lifestyle changes. So it's as effective as that. Now, obviously, there's not decades to look at outcomes data to support this yet, but the data is pretty clear so far. Obviously, contraindications, so renal artery, especially fresh renal artery stents, and pregnant patients, which is true for essentially every new device. So I talked a little bit about this. So the connection between the brain and the kidney is what we're trying to interrupt. So the cool anatomy slide is I want to see how complicated this is. When we look at a textbook and you just see a little line that's like kidney to brain, it's a way, way more complicated. So if you can see, there's actually a accessory artery there, a regular renal artery that branches, and these nerves just grow in this big, funny, spidery plexus all over the arteries. That's one of the problems that made some of the earlier devices that were more spot treatment not do very well, is because these nerves grow all over the arteries. And if you look at the accessory, there's actually even more nerves on the accessory artery than on the true renal artery. So it's a very complicated spider web that's not straightforward. Nothing's going straight. Excuse me. And then the good thing is that it really hugs the actual artery itself. You can see in the middle of the slide, that's the renal artery coming in and out at you, and this nice nerve that's all around it. So the good thing is that when you're using energy from the arterial side, you actually get the nerve that wraps around it, which makes ablation very effective because it's so close to that area. Now I want to talk, and this is a little bit about, specifically with the RF device, is some of the earlier trial experiences. I kind of said the 5 to 10 one, but that's some slightly older data. Now if you look at the newer trials, which are sham controlled, and if you know anything about the older trials, they were marred by the treatment effect of the sham arm was so high that it made the device not effective, that newer trials were mandated to have some sham control, which is good in a general clinical trial setting. But we're talking at 3 months, 9 systolic point difference, and then on the second to newest trial, or the non-registry trial, we're talking 9-17 at 2 years, and 3 years, almost 20 points. So the difference is very high, and this is almost even better than some of the lifestyle modification measures I mentioned earlier. And if you look at the newest registry, which is the biggest data set, these numbers are essentially the same, and that's what we're seeing right now. So again, at 3 years and even more data, that's even in the global scale, we're getting the similar numbers, basically in the teens, high teens at 2 years. And I want to also mention it's not an overnight fix. I get a lot of phone calls now about, I have an inpatient, I want to fix their blood pressure tomorrow. This is absolutely not the case. It is going to take months for that to work, but it is very durable and works for 24 hours, which brings us to the next thing. Medicines have metabolisms. They have different peaks. Blood pressure moves up and down depending on the day. The best part about this is if you look on the bottom and the top, the difference is there all the time depending on the baseline. So as your blood pressure naturally increases, your peak blood pressure is now lower post-renal denervation than it was before. So it's kind of hard to see this slide a little bit, and I'm sorry, but I'm just going to tell you what to do. So screening is if they're still having high blood pressure, first thing is to rule out secondary causes, which is renin and aldosterone. You can talk about looking for anatomic renal artery disease. That's usually what I do as accepting referral one, but sleep apnea, alcohol use, that's the type of stuff that I want to do first. So stuff that you want to do up front, or what are you going to remember from this guy rambling up here for the last 20 minutes? I want to sum it up with kind of 2 cases. And this is the stuff that's going to change, so some poor medical student will have to answer these questions differently in the near future. So a 54-year-old, stage 1, but has diabetes and high risk. The change from the last one, if this was a test question a year ago, it would not be. It would say lifestyle modification, bring them back in clinic. The new guideline, again, is start medication up front. And then second case, 3 medicines, stage 2, still above goal. You can add a 4th medicine, screen for other things, and refer to a hypertension specialist. So if you want to remember any stuff, remember these couple things, those last 2 slides really. So assess for risk score when you risk beyond hypertension, let's just prevent or other cardiovascular risk scores. When you treat with someone with hypertension, make sure to look for other causes, including primary hyperaldo and renal disease in people that have hypertension, and jump to 2 medicines up front in people that have more than stage 1 hypertension. And the most important thing, because obviously I'm on the other end of this, is people that have advanced hypertension, and this market is huge, and that's again 3 medicines and still not at goal. Get them to see us so that we can talk about renal denervation. That's it.